So, per request, somebody wants us to talk about Lyme disease and neuroborreliosis, which is kind of the neuro-op version of Lyme disease. And you should know that this is a tick-borne illness, and the organism is Borrelia burgdorferi, and it's the deer tick that transmits the organism. And so one of the things we need to know is a little bit about the epidemiology of how did the person get this Lyme. Now, Lyme has a countrywide distribution, but in the United States, 95% plus cases come from just 4 parts of our country. So if you're looking at the United States, really it's going to be the Northeast corridor centered on the famous Lyme, Connecticut, but all of these parts of the New England, Martha's Vineyard, all those places. And then we've got this chunk in the middle here, which is like Minnesota, Wisconsin, this Midwest piece. And then you got this Northwest corridor here, like Washington State, Oregon. And then you got scattered communities in the South and in other places that have less, but it's not endemic like it is to the Northeast. So when we see patients in Texas, which is a not endemic part for Lyme, we'd like to know, where did you go? Oh, I was in Minnesota fishing. What'd you do? I was camping outdoors. And what time of year was it? It was May, it was spring. And did you have a tick bite? The second thing we want to know is if they had a rash. And even though the book says the rash should be a target-like lesion, it really can look like a lot of different things. However, the one we're looking for is called erythema chronica migrans, which is going to be a bullseye type target lesion with a central clearing on an erythematous base. ECM, erythema chronica migrans. And so this comes to us just like syphilis. So anytime you have syphilis in the differential, you also have to have Lyme. Like syphilis, there's a primary, a secondary, and a tertiary stage. And so for neuro-op, we're often seeing the patient in the tertiary stage. In the secondary stage, just like syphilis, it's the uveitis phase. And the primary, I never get to see that because that's the tick bite and erythema chronica migrans. So in this acute primary stage is the non-eye finding part for neuro-op. We are normally seeing tertiary and secondary Lyme. But here in Texas, they have had to travel to an endemic area or be from an endemic area before I'm going to consider the Lyme. And for Lyme disease, we have a 2-tier testing strategy. The first tier is the screening, which is the ELISA, an enzyme-linked immunoabsorbent assay. And this test is not very sensitive and specific, and so you have to do a confirmatory gold standard, which is the Western blot. The Western blot is going to have bands, and the CDC has defined exactly which numbers you have to have, and I can never memorize them. So it's like number 39, number 43, number 52. So it's like bingo. If you have 5 of these, bingo, because you got a 39, a 43, a 52, and you have to look up all those numbers and the types that we are looking for. And then if you have any kind of itis, that is what we're looking for. So from the front to the back, episcleritis, conjunctivitis, scleritis, keratitis, keratoconjunctivitis, iritis, intermediate uveitis, vitritis, chorioretinitis, optic neuritis, meningitis, meningoencephalitis, cranial neuropathy-itis. It's just itis, basically. And that's why it's always in the differential diagnosis for neuro-op, because it can look like anything. So it's one of those great mimickers, just like syphilis and sarcoidosis. And of course, the treatment you should leave to infectious disease. They're going to have their own regimens in terms of tetracycline derivatives versus ceftriaxone. It's constantly changing. We're going to do the lumbar puncture to look for evidence of CNS disease. And if they're treated with antibiotics, the CDC says it's a one and done. So, however, you need to know that there's a chronic form of Lyme that is very controversial and is referred to as post-treatment Lyme disease syndrome. And so those patients often have chronic fatigue and they have chronic unexplained residual symptoms, even though they don't have the itis anymore. So these post-treatment Lyme disease syndrome patients can come to you in neuro-op, but I just look for the itis and optic atrophy. So if I don't see any objective finding, they've already been treated with antibiotics, then I just reassure them and let them be treated by whoever they're being treated by for homeopathic or non-Western alternatives. But the official party line of the Infectious Disease Society of North America and the CDC is once you've been treated for antibiotics, that's the end of the treatment. But there is this post-treatment syndrome that exists, so the patients do have symptoms. So you need to know a little bit about Lyme disease. It can present to me as neuroborreliosis. You should ask them where they went, what they do, what time of year it was. If they had a tick bite, the rash of erythema chronica migrans, look for itis, treat them with antibiotics. Got all that?